welcome Dr. Jamil. So Dr. Jamil, please, you can share your screen.
Okay, everybody. So first of all, I'd like to make sure that you're all hearing me. Can everybody hear me? Okay, perfect. So what I want to do today is I do want to talk about twins. So, and I think twins is a very fun and important topic at the same time. And we're going to have a lot of fun today. We're going to do a lot of learning. Okay. So the goal of any lecture that I give is learning in a fun way that minimizes the amount of memorization that you guys have to do. That for me is very, very, very important. So what is, or actually it's not going to be just twins, it's going to be multifetal gestation. So when we say multifetal gestation, what do we mean? It is any pregnancy that has more than one baby, right? Of course, the most common of these is definitely twins. So why do you guys think the incidence of twins is increasing? Why do you think we have more twins nowadays? Yes, I'd like to see participation. IVF is one, and what else? Believe it or not, it is the gestational, it's the age that the mothers are actually getting pregnant at is now later on. So the later the mother gets pregnant, the more likely she is to have twins, which is probably, to do with the amount of FSH that recruits those follicles. You have those follicles with the higher FSHs towards the end of reproductive ages may recruit more follicles. All right, sounds good. Now, here's what I'm going to do. I'm going to do something that I think is going to be beneficial for a lot of us. Whenever I finish a specific part of the lecture, I'm going to put it in a diagram. And that same diagram is actually going to follow us as we move on. So what type of twins do we have? We have monozygotic and we have dizygotic. What's the difference? We're going to talk about that. Okay? So monozygotic twins result when one egg is fertilized, when a single fertilized ovum, right, divides into two identical cell lines. And that actually is about 30% of all twins. And can you all tell me what type of twins can happen from monozygotic? What type of twins can happen from a monozygotic pregnancy? Let's see. I want participation. Yes, so we've got monochorionic diamniotic, mono-mono, right? Mono-di, and what is the fourth one? Can anybody tell me? Conjoined twins. Excellent, excellent, excellent. So what determines which type of twin we get? It is the timing of cell division. Keep this in mind. Remember I said I'm going to minimize the amount of memorization that you're going to do? The earlier something divides, the more likely you are going to get more copies of everything, which means earlier divisions is going to result in diamniotic, dichorionic pregnancies. What does that mean? You are going to have 2 placentas, 2 chorions, and 2 amnions, all right? Does that kind of make sense? All right. Perfect. And the division, and this is the first number that I want you guys to put aside. When the division happens early before 4 days, it is monozygotic. Sorry, it's diamniotic, dichorionic. If the division happens between 4 and 8 days, it is going to be monochorionic diamniotic, which means they will share 1 placenta, but more importantly, they will share only 1 chorion. 1 chorion, but 2 amnions. All right? Now, if you have monochorionic, monoamniotic twin pregnancy, that means the division happened somewhere between 9 and 12 days. They will share 1 placenta, 1 chorion, and 1 amnion, meaning there's no dividing membranes between those 2 twins. What is their unique complication? And that's what we're going to talk. We're going to talk about each type of twin, and they're going to talk about their unique complications as well. So the unique complication of this type of twins is what? Cord entanglement. Okay, so before I continue, is everybody paying attention? Is everybody enjoying the lecture so far? Right? I want responses. Come on, I want to see responses. I want you guys to be, now here's the deal. I think this lecture is not fair. You know why? Listen to me. You know why this is not fair? How many of you are still fasting? Well, I am, right? So I can't have my nice little cup of coffee next to me. All right? So there you go. Okay? So now, if I'm putting all this effort and being energetic, you guys that have eaten, unless you've eaten too much, have to be energetic with me as well. All right? Sounds good? All right. So now, when we talked about dizygotic twins, monozygotic twins, they're usually identical. Now, dizygotic twins, they are fraternal twins, and they result from multiple ovum separated by different sperms. And what they do is they comprise the overwhelming majority of all twins, and they account for 70% of all twins. Now, here is what I want to tell you. Dizygotic twins will always be dichorionic, diamniotic. They will always be dichorionic, diamniotic. Is that clear? Is that clear? Okay, so if I tell you monochorionic, diamniotic, it's not going to be a dizygotic twin pregnancy. Perfect. So the higher incidence rates, like I said, we said based on infertility treatment, family history, it is more prevalent in certain African populations as well. All right, this is just a diagrammatic drawing of different types of twins. Now, this is the diagram that I am talking about. And this is a very good way that if you guys want to study and summarize, is what we will do in the end is our last slide is actually going to be a summary of everything that we actually talked about in a diagram. So what did we just say? We said twins can be dizygotic and monozygotic. Monozygotics account for 30% of pregnancies. Dizygotics account for 70% of twin pregnancies. All dizygotic twins are dichorionic, diamniotic. Isn't that cool? Now, monozygotic pregnancies, and I excluded conjoined twins because we're not going to talk about them much. Dichorionic, diamniotic, monochorionic, diamniotic, and monochorionic, monoamniotic. All right. So guess what I did for you guys? I also put the timing of the splitting in one slide so that it can be a reference for you. Now, for those of you that are taking exams or doing multiple choice questions and stuff, sometimes the question specifically asks you the time of splitting, but sometimes the question is a little bit more complex and they actually want to know the cell stage. So guess what I did in this slide? I put for you the cell stage. So if the examiner wants to be a little bit cheeky, they may say, dichorionic, diamniotic twins happen in which cell stage, and then it becomes the morula, and so forth. Okay? Now, here's what I also want to say. Those of you that are studying for exams, right? Okay? And those of you that are not, the key to memorizing any topic or recalling the information is to actually have a cheat sheet for you. So in the end of the day, what you do is you take a big topic, you put your notes to the side, and then you make a small cheat sheet. That way, when you revise or you do anything, you don't have to read pages and pages of something. And this is what I'm going to do a lot of in this lecture. All right, perfect. So how can we differentiate between types of twins? Or first of all, let me go back. First of all, somebody comes in, what makes you suspect that they have a twin pregnancy? They'll come in and they'll say, okay, let's track back a little bit, okay? Let's understand a little bit more about twins. So if I have twins, I have more of what? More placenta, more baby. So immediately, what do you think of? And this is how I want you guys to think, right? Even though this is not on a slide, I just want you to think how understanding here is very key. So if I have two placentas, what hormone is produced more? HCG. HCG is associated with what? More nausea and vomiting. Correct? So now, if I have two babies, each one of these babies has a chance of having a congenital malformation or aneuploidy. So now the chances is doubled. So twins have more risk of having aneuploidy and structural malformations. Let's think a little bit. Placenta is more. Which other hormone is produced in the placenta? Human placental lactogen. And that is associated with diabetes. So twins are more likely to be diabetic, right? See how none of this is memorizing, right? Especially in twins that share the same placenta. Aren't they more likely to fall off the growth curve? Absolutely. So there is an increased risk of IUGR. See, none of this is memorization. This is all understanding. Well, if we have two babies, don't you think that that increases the chances of malpresentation / more likely to have cesarean deliveries? 100%, right? And then if the uterus is overdistended because of those twins, aren't you likely to have preterm birth? 100%. What about postpartum hemorrhage after delivery? There you go. See, these are the majority of complications of twins that are common to all twin pregnancies. They're all stemmed from understanding. And if you know, then you know. All right? So let's move on a little bit. Now, a patient comes in and she says by the last menstrual period, she thinks that she's about 13, 14 weeks. And when you're doing your exam, the fundus is higher than what you would anticipate. Now you go through what could be the cause of the fundal height gestational age discrepancy. And of course, one of the things that comes up is a twin pregnancy, correct? So then you go ahead and how do you confirm that you have a twin pregnancy? What do you do next? You do an ultrasound. Now the ultrasound will either show one baby, two babies, three babies, four babies, whatever number. So your next step is to say, well, I need to identify which type of twins it is. And why is that important? Why is the type of twin important? Timing of delivery and management and unique complications, correct? So di twins have the least amount of complications. Mono have the most amount of complications, right? Now, out of all of these twins, what is the most common complication? What is the most common complication? It is preterm birth. It will always be preterm birth, okay? Please do not forget that. The most common complication of twins is preterm birth. It's not twin-to-twin transfusion. It is preterm birth, right? So let's move on a little bit. What ultrasound findings will tell me what type of twin it is? If I see no membrane separating the twins, then that is monochorionic monoamniotic. Now, if I see a dividing membrane, how do I know which is which? If I see two placentas, that immediately tells me it's di-di, right? If I see boy-girl, what does that tell me? It is di-di, and it's also dizygotic, right? It is also dizygotic. Now, if I see a twin peak sign or a lambda sign, that also tells me it is dichorionic diamniotic as opposed to a T sign. Now, how many of you have heard of the lambda sign and the T sign? How many of you have heard of them? How many of you have memorized them? Okay? No memorization after today, because I'm going to explain to you what they mean. All right? Now, didn't we say there were more cell layers in a dichorionic diamniotic twin pregnancy? We did. So don't you expect that the dividing membrane is going to be thick as opposed to a thin dividing membrane. Thick dividing membrane, thin dividing membrane. Okay, so there's nothing better than showing you these signs. Can you see how the dividing membrane here is that thin or thick? It's thin, right? Is there a dividing membrane? Absolutely. Does this look like it is one placenta? It does. Does this look like a T? All right. Those of you that have any doubts, there you go. All right. It is a T sign. It's an inverted T, but nonetheless, it's a T sign. All right. See that? Okay. As opposed to, what is this? Does anybody know what this is? What is this? This is the lambda, right? And then what is this? These are nice two mountains, correct? These are two mountains on there. Can you see them? This is one peak, and this is another peak. And that is what is referred to as a twin peak sign. Isn't that cool? So I told you, no memorization after today. Let's look. Does this membrane look thick or thin to you? It looks thick. Can you see this here? With a little bit of imagination, what does it look like? A lambda, right? All right. And here you go. Let's make this even more fun. With a little bit more imagination, guess what it looks like? A twin peak. Isn't that cool? Right? Now, do you guys think you have a better understanding of the ultrasound findings that can differentiate twins for us now? Agreed? All right. Now, let's see. We jumped a few slides. Okay, so let's do some housekeeping. We talked about this, right? Regardless of the symptoms, right? Most complications will overlap between all twins. And a physical exam will show us a uterus that is large for the gestational age. We do an ultrasound. Twin A will usually be closest to the cervix. Hyperemesis is a common symptom, and HCG levels will more than double every 48 hours in an early twin gestation. Where's that a problem? Right? That sometimes can be a problem, right, in ectopic pregnancies, correct? Because your doubling time is earlier. Okay? So, how is that a problem in an ectopic pregnancy? Can anybody explain to me? That means you will potentially reach the threshold where you expect to see a gestational age earlier because the HCG is high. However, you won't see your gestational sacs because there's two of them and they're still smaller. Is that making sense? That's why you have to be very cautious. When we use the cutoff for beta HCG, it is not perfect because in twins, you may have a beta HCG of 2,000, 2,500. You still can't see your gestational sacs because they are still small. Now, here's another point for you. If you are dating twin pregnancies, which measurements should you use? The bigger one or the smaller one? The bigger one or the smaller one? You should always use the bigger one, all right? Because you anticipate that the other one is small, and that way you reduce your chances of missing an IUGR. They always tell you when you have a twin pregnancy to use the bigger one, all right? Now, the other part of it is also the earlier you do an ultrasound, the more likely you are to be able to identify correctly what type of twin pregnancy you have. Perfect. All right. We talked about all of these complications. See? Preterm labor, congenital malformations, IUGR, preeclampsia, hypertension, gestational diabetes, cesarean delivery, postpartum hemorrhage. So you see, none of these now are memorized. None of these are memorized. They're all understood. Okay, so on average, right? Each pregnancy takes away about 3 weeks from the pregnancy duration, on average. Okay, that's just a good rule of thumb. And you can see if you have more preterm birth, there's more risks of cerebral palsy, infant mortality, and so forth. Okay. This is the antepartum management. You're supposed to do fetal growth scans every 4 to 6 weeks. And if you have monochorionic twin gestations, you're supposed to do twin-to-twin surveillance every 1 to 2 weeks. And remember, antenatal testing is not routinely recommended in dichorionic twins. Antenatal testing is definitely recommended for monochorionic twins, and admission is recommended for monochorionic twins at 24 weeks. Unfortunately, prenatal screening for twins is not as good as singleton. Our quad screen and our cell-free DNA are not as accurate. However, amnios and CVSs can still be performed. This one you all know, but this is just a reminder that if you have preterm labor, you can give them tocolytics, corticosteroids. Now, the biggest change that has happened with corticosteroids lately is we have started giving them at 23 weeks as opposed to 24 weeks. All right, and then magnesium sulfate for neuroprotection. Now, let's kind of pay attention to each other for a minute, right? These are things that unfortunately do not work for twins and prevention of preterm labor. So how many of you, just out of a show of hands, how many of you actually still do cerclages for twins and short cervixes? Any of you still do cerclages with twins and short cervixes? No. So the recommendations from the American College is not to do that, all right? However, the exception to that could be if someone has a history of incompetence prior to becoming pregnant. So if somebody had 2 mid-trimester miscarriages, then had a cerclage, and now they're pregnant with twins, that may be the only exception. However, you know how in people with preterm births, if the cervical length is less than, right, 2.5, you're supposed to offer them a cerclage, not with a twin pregnancy. Also, hospitalization does not help. Prophylactic tocolytics do not help. Pessary has not been proven, and giving them 17-hydroxyprogesterone has not been proven. All right, so for a minute, I want you guys to pay attention, all right? I feel that some of you are not awake. Did you guys take too much futur? Is everybody awake? Are you all here? Are you all enjoying the lecture so far? And learning a lot? All right. Sounds good. Because it's only going to get better, right? It's only going to get better. See the diagram that I told you about? Look at what I've just done for it, right? I've put dichorionic diamniotic twins, and this is the one, this is the only one that can have gender discordance. Can you see? So if I give you a boy and a girl, it has to be dichorionic diamniotic twins. Then I've listed the rest of the stuff underneath. Then when we have dichorionic diamniotic, right, the division time is less than 4 days, and it can't be gender discordant. Monochorionic twins, there you go. See how we're adding to this diagram and making it very nice? Okay. Timing and route of delivery. For uncomplicated di twins, we normally deliver them at 38 weeks. For uncomplicated monodi twins, we usually deliver them between 34 and 37 weeks and 6 days. For uncomplicated mono twins, they're usually delivered between 32 and 34 weeks. And triplets are usually delivered at 35 weeks of pregnancy. All right, now, let me ask you some questions and I want you to answer them for me, correct? Is it possible to deliver twins vaginally? What is the prerequisite? Not both cephalic. Only the first twin has to be cephalic. So twin A needs to be cephalic. All right? Now, what is prerequisite number 2? Prerequisite number 2 is the delivering provider has to be comfortable with delivering a twin pregnancy. Believe it or not, prerequisite number 3, right, and a lot of you make that mistake, is they cannot be monochorionic, monoamniotic twins. Monochorionic, monoamniotic twins. Because all monochorionic, monoamniotic twins, irrespective of presentation, have to be delivered vaginally. So, for us to be able to deliver twins vaginally, they cannot be mono-mono twins. That's number 1. They cannot be mono-mono twins. Number 2, right? The first twin has to be cephalic. Is that making sense? And the reason why we can't do mono-mono twins is because of the cord entanglement. Once one baby starts to come out, those cords are going to become entangled together, and they will cause the baby to have a lot of problems. Okay? No, so mono-mono, it can't be mono-mono, and in other types of twins. Okay, so let's I think there's a little bit of confusion here, so let's clarify. All mono-mono twins have to be delivered by C-section. All mono-mono twins have to be delivered by C-section. 2, in monochorionic diamniotic and diamniotic dichorionic twins, right? The first twin has to be cephalic for you to deliver vaginally. Is that clear? All right, let's move on. If we have issues with that, we can come back to it, okay? Now, does anybody know why? If the second baby, all right, if the first baby is breech, why we don't deliver vaginally? Does anybody know? What are we worried about? Head entrapment. Look at that. See? You worry about interlocking heads. Can you see that? That's why the first twin has to be cephalic. Okay? And you know what? I've been doing exams for a very, very long time. You know what is the most common mistake that a lot of you make on an exam is when they present a question as following. They will say a mono-mono twin pregnancy comes in cephalic, and she's 8 centimeters. What is the next step or the next step in management? Remember, mono-mono, all of them have to be delivered by C-section. All right, and this is a table showing you the timing of delivery. Now remember, when I gave you the first slide, we said that di twins are delivered around 38 weeks, provided that they are uncomplicated. If they become complicated and they have isolated IUGR and stuff like that, then you have to bring forward the delivery to around 36 weeks, right? Monochorionic, monoamniotic twins, uncomplicated, are delivered at around 34 to 37 weeks. When they have isolated IUGR, you bring forward the delivery timing to 32 weeks. Monochorionic, monoamniotics, you deliver them at 32 weeks. Okay, let's move on. Oh yes, absolutely. That's a typing error. I apologize. It is monodi. Okay, you're absolutely correct. Those that pointed out the second 2 lines are monochorionic diamniotic. I apologize for that. Okay. All right. So these are some twins that I delivered a couple of years ago. So it tells you that twins are very, very dear to me. All right. And this is what these twins look like today. And now they have another baby sister. All right. And that's what makes our specialty very unique, is you actually share a very common, you share a very happy time with parents. And then after that, when they come and visit you in the office and stuff like that, they bring the kids, and it's very nice. And I think that's what makes our specialty unique and much nicer than a lot of the other specialties out there. Okay, speaking of which, unique complications. Let's take each one of these complications and talk about the unique complications that we have. So what are the unique complications of monochorionic diamniotic? What is the unique complication of monochorionic diamniotic? What's the most common unique complication? Twin-to-twin transfusion syndrome, correct? I agree. What is the unique complication of mono-mono? It is cord entanglement. But there are some other complications that can come along the way, such as autoreduced twins, single twin demise, IUGR of one twin. And those of you that don't know, that's fine, we're going to talk about it. But TAP and TRAP. Has anybody heard of TAP and TRAP? Any fellows out there? TAP and TRAP. All right, we will talk about them. Any MFM fellows, in this lecture? No fellows? All right. Okay, so we'll talk about the TRAP and TAP, okay? Now here you go. Autoreduced twins is simply a twin pregnancy or a multiple pregnancy that went from whatever number it was to a less number. So if we had twins and it became singleton, that is known as an autoreduced twin or a vanishing twin. The probability increases with the increasing number of fetus. Thankfully, once the twin reduces, it doesn't have any repercussions or ramifications on the pregnancy, and the pregnancy continues without any issues. Single twin demise is very important. So what do you do if one twin passes away? Okay, and what consequences does that have on the pregnancy? What do you think the problems that can arise are? Okay, what do you think are some of the problems that can arise? So first of all, if one twin dies, then the death of the second twin also increases. And in monochorionic twins, if one twin dies, there is a 15% chance that the other twin will die as well. However, usually that death happens together, and all the complications usually happen at the time of the death of the first twin. Now, in dichorionic twin gestation, the risk of death of a second twin is about 3%. What other things can happen? It increases the chances of neurological abnormalities. It increases the chances of neurological abnormalities. And also, if they share one placenta, one feeding source, all that sort of stuff, the blood supply can interchange, then the risk of these toxins going from one baby to the other increases. So it is more likely to have neurological problems in monochorionic gestations, versus dichorionic neurological abnormalities happen in 1% of the surviving twin. This is where it's an impulse thing. If one twin passes away, do you have to deliver the second twin? Do you have to deliver the second twin? And the answer is no. You would only deliver the second twin, A, if you were at a gestational age where delivery would be indicated anyhow, right? So generally speaking, if you're after 34 weeks, there's no benefit in keeping them pregnant. Number two, if there is anything to suggest that there is fetal compromise or fetal well-being is jeopardized. All right. So that's single twin demise. Twin-to-twin transfusion. And here is where understanding becomes critical. A lot of you find this topic a little bit difficult. It can only happen in twins that share a same placenta. So it cannot happen in diamniotic dichorionic twins. It can only happen in monochorionic twins. Why? Because there is an anastomosis between the blood vessels, right? So think of it this way. If more blood goes to one baby as opposed to the other one, so there's more circulation going to one baby, what is going to happen to the baby that has the more circulation? It is going to, and laugh with me, it is going to pee more. And if the baby pees more, you are going to have more fluid around the baby, as opposed to the baby that doesn't have as much circulation. what is going to happen? It is going to P less. So the first thing that we see with twin-to-twin transfusion syndrome is oligo, poly. Poly, oligo. Think of it that way. More blood flow to one baby, more urine, more amniotic fluid. Then after a while, what is going to happen? In the baby that doesn't get a lot of fluid, you're not going to be able to see the bladder and the stomach. Then the baby that's not getting a lot of the circulation is going to become small, have abnormal Dopplers. On the flip side, the baby that is getting more blood flow, what is going to happen to that baby? It is going to become big. You are going to overload that baby's heart. And once you overload that baby's heart, it is going to become hydropic. And we said hydrops is just a fancy way of saying more fluid around the baby. And if the baby becomes hydropic, then after that, the baby will die. See how easy that is? Now that you understand it, doesn't that make it a lot more clearer now, right? Understanding. So then what do? We need to make sure that that does not happen. So for monochorionic diamniotic twins, we bring them every 1 to 2 weeks and we do a limited ultrasound looking for fluid, Doppler studies, and sometimes growth. See? Theoretically, it can. It is very, very rare, but it can happen in mono twins. The problem, though, with mono twins is because they share the same sac, you will not be able to tell if you have polyoligo. You will not. But for whatever reason, it's extremely rare to happen in mono twins, but it can happen because they do share the same placenta. All right? The size of the fetus can be an indicator, right? But again, you won't be able to tell between oligopoly. You won't be able to tell based on bladder not being filled because both babies will be able to. But yes, absolutely. If you see one baby big, one baby small, and you start seeing abnormal Dopplers, you can suspect it. So the baby, like we said, that gets more blood flow actually has a worse prognosis because of that strain that is on the baby's heart. The baby's heart becomes bigger. So once they're born, right, the recipient twin has a worse prognosis than the donor twin. Now, how do you think we can fix the problem of twin-to-twin transfusion? Right? What is the easiest way to fix the problem for twin-to-twin transfusion? You tell me. Come on. You basically make them into di twins, right? So you do laser ablation and you basically split the placenta and make it into 2. That's the ideal way. Sometimes, unfortunately, laser ablation is not available, or laser coagulation is not available. So you can do amnioreduction. Amnioreduction, though, does not help in solving the problem long-term. It may solve it short-term, but it doesn't help solve it long-term. And of course, if the baby is at a gestational age where delivery is indicated, you can go ahead and do the delivery. All right? Perfect. Excellent, excellent. All right, are you guys still awake? All of you have your coffees except me? Am I the only one without coffee? So, I can tell you this much. None of you will graduate residency without graduating the coffee residency as well, right? I've yet to see an OBGYN resident that does not drink coffee. All right, sounds good. And gets the Ramadan headache, right? Sounds good. So remember what we talked about, oligo, poly, bladder is absent, abnormal Dopplers, hydrops, and death. There was a wonderful person by the name of Quintero that staged it, okay? That staged it. And it's based on what we talked about. Now, let's talk about TRAP. Twin reversed arterial perfusion. Now, those of you that are in residency or medical school, you know, if you get asked about this and you answer it, man, whoever you answer it to is going to be extremely, extremely impressed with what you tell them. Extremely impressed. So what happens in TRAP is you get one baby that is normally developed and another baby that does not have a heart. So it doesn't have the ability to pump blood. So the twin that is, the normal twin will act as the pump for the other twin. And you can see where that is a big problem. And about 50% of these patients will die. Now, unfortunately, about a year ago, or just a bit over a year ago, I had one of these patients that came to the office and we diagnosed her with TRAP. Thankfully, about maybe 2 months ago, she came back again and she's pregnant with a normal pregnancy. And I tried to look for the images that I had to bring them and show you, and I couldn't find them. So I have seen that happen. It is extremely rare, but I've actually seen that happen. Can you believe that? Oh, the person that put twin anemia polycythemia syndrome, Marwa, we're going to talk about that in a minute. TRAP is different. TRAP, there is no anemia polycythemia. It is one baby working as the engine for two babies, right? Think of it that way. One baby working as the engine for two babies. Okay? Perfect. Speaking of which, this is what it looks like. Can you see? And because I don't have a picture, I actually took this from the internet. This is why I left the credits there so that we don't steal pictures that are not ours. Okay, but that's what it looks like. A baby with no fetal head, no heart, and a baby that is normally developed that acts as the pump for the other baby. Okay, cord entanglement. This was a patient that we delivered recently with mono twins, and you can see how the cords are entangled. Isn't that cool? Okay. Now, twin anemia polycythemia sequence. What is that? That is basically when you have a connection and the anastomosis, instead of it being full-blown twin-to-twin transfusion syndrome, one baby transfuses blood to the other baby. So the baby that transfuses the blood to the other baby will become anemic, and the baby that gets the blood transfusion will be polycythemic. The baby that transfuses will be anemic, and the baby that receives the blood transfusion will be polycythemic. Now, remember when we talked about last lecture and what we're going to talk about? How do I screen for anemia in babies? What can I do to know if a baby's anemic or not? I can measure the middle cerebral artery, Doppler. Excellent, excellent. I'm very impressed with you guys. Now, anemia is usually looked at based on the peak systolic velocities and multiples of the median. If they are above 1.5, that usually indicates that the baby's anemic. Now, on the flip side, how do you know that a baby is polycythemic? If the peak systolic velocity is less than 1 multiples of the median, right? And the other one is more than 1.5, that is anemia polycythemia. Now, it can be even more severe than that. If one of them is 1.7 and the other one is less than 0.8, this is a very severe form of anemia polycythemia. Now, usually this happens after laser ablation, but it can happen without laser ablation. Okay? It happens because of the because of the connections between the, since they share one placenta, there is vascular anastomosis. And if there's vascular anastomosis, one baby is able to transfuse the other baby. So the baby that transfuses will be anemic and the other one will be polycythemic. Okay. Now, unfortunately, there really is not, here it is, occurs due to a slow transfusion of blood from the donor to the recipient through very small arteriovenous vascular anastomosis. Okay, there is no substantial difference between the twins in either size or amniotic fluid, so you can't really pick it up. The way that you normally pick it up is unfortunately, either one baby will be hydropic because of the anemia, or when you do the peak systolic velocities, one of them will be above 1.5 and the other one will be less than 1. Okay? Treatment and timing of delivery is controversial. And that's why I'm not going to go through it. Okay? These are the types, and I'm not going to go through this at all, but these are the types of conjoined twins. And this is just for your reference, you know, based on where the conjoint, where they're conjoined, right? And again, this was taken from the internet, but you can see they can be conjoined at the thorax, they can be conjoined at the head, they can be conjoined in all sorts of different places. All right. So, any questions so far? Anybody have any questions? Anybody have any questions? It is a form of twin-to-twin transfusion, but not. Okay, so what do you want to know about selective IUGR? Yes, so twin-to-twin transfusion syndrome. Okay, twin-to-twin transfusion syndrome, you get oligopoly, right? And then after that oligopoly, you get one baby that gets more blood supply, right? No transfusion of blood. So one baby gets more blood supply, but there's no anemia. And that baby has a lot of load on its heart, and then the Dopplers become abnormal. And when I talk about Dopplers, it's the umbilical artery Dopplers, and then after that, baby dies. The other one, different, same anastomosis, but a different mechanism. What happens is the blood, the baby, one baby transfuses blood to the other baby. And when that happens, you get one baby that becomes anemic, and the other one, because it had a lot of blood transfused to it, has polycythemia because of the high blood that it got. Okay? Any questions so far? Anybody has any questions? No. So when we go back, when we go back to this slide, and I'm actually done. Let me do this. Let me finish the one slide that I have, and I will go back to selective IUGR. Okay. So this is a summary, okay, of everything that we talked about. This is a summary of everything that we talked about. So if you look at it, if you actually look at this slide here, if you look at this slide here, you know what this does? It is a very wonderful summary because it summarizes everything that we just talked about. So like we said, twins can be dizygotic, monozygotic. Dizygotic can be dikaryotic, diamniotic. This is how you know what they are, and you deliver at 38 weeks. Dichorionic, diamniotic, again, you deliver at 38 weeks. The only thing that is different from here is they cannot be gender discordant. Monochorionic, diamniotic can have TTS, trap, and tap, and you usually deliver between 34 and 37 weeks. Monochorionic, right, deliveries between 32 to 34 weeks and no vaginal delivery, all right? And that is really the summary of the majority of what you're gonna need to know for twins, wherever you are, okay? And those of you that have poor eyesight like me, I just increased the size for you, okay? Just in case. All right, you guys probably have better eyesight than me, so I'm getting old. Okay, so let's go back to some of those slides there. Okay. All right. Okay, so, all right. So like I said, there's a typo in this one, but dichorionic, diamniotic twins with just isolated IUGR, meaning one baby is well grown, one baby is not. Instead of delivering them at 38 weeks, you bring the delivery date forward to 36 weeks to 37 weeks and 6 days, if it is selective IUGR. Now, I didn't go into it, but if you have other complications, if you have abnormal Dopplers, then it is individualized. But that's why they say isolated IUGR. When they say isolated, that means no abnormalities in the Dopplers, nothing else, no other abnormalities whatsoever. When we go to the monochorionic monoamniotic twins, right, with the monochorionic monoamniotic twins, they're uncomplicated. We deliver them at 34 weeks. If they are, the monochorionic diamniotic twins, uncomplicated, we deliver them at 34 to 37 weeks. The monochorionic diamniotic with isolated IUGR, you deliver them between 32 and 34 weeks. Okay? Now, like I said, the take-home message for this for this presentation is this slide, because it really summarizes everything that we went through almost, and it exclusively summarizes what you guys need for most of the exams that you guys will be taking. Right now, those of you that are in medical school, TRAP and TAP that we talked about is probably something that you will not be asked about. It is really great to know, and if you're a fellow or a resident, then it's great that you know about it. Okay. And then remember, the unique complication of mono-mono is cord entanglement, and you cannot perform a vaginal delivery. Okay, look at that. I'm going to end with these two slides. See, this is a 3D image of a lower extremity. And if you can see, what we initially, when we were actually scanning this patient, we couldn't find a femur on both sides. And the other bones looked like they were short, they were fused. And initially we were suspicious that this was Serenomelia or a mermaid. However, what threw us off is the second limb. Can you see that? That's actually how this baby looked after it was born. But isn't it amazing, though, that we managed to diagnose this and look at the similarities between those two extremities there? Isn't that amazing? And this is somebody who actually came to us late in her prenatal care, and we saw her for the first visit at around 34 weeks. So I thought it was really cool that we managed to get that. Don't you guys agree? Yeah, so she was a severely poorly controlled diabetic, and even though this was what we saw, it was a severe form of, there was femoral agenesis, and the spinal cord was not well formed. That was the diagnosis in the end, and it also had a congenital malformation. Okay, so I hope you guys enjoyed today's lecture. I'm really glad that you guys joined us, and I hope that you benefited and you had a lot of fun. Again, like Dr. Better was saying, all of the upcoming lectures are going to be on Facebook, Twitter as well. I would encourage you guys also to interact with me on Twitter. If you have a discussion that you want to involve me in, just put @ and put my name in it. And I love a discussion. And those of you that have specific questions, don't forget you can email me. You can do a lot of things.
Well, thank you very much, Dr. Jamil. It was a beautiful lecture. I'm sure everyone benefited. I would like to now, if there are any questions, please write down your questions so we can address them, and Dr. Jamil addresses them. So, any questions so far? We're gonna, inshallah, work on uploading that on YouTube. So this lecture will be, inshallah, handled and uploaded on YouTube inshallah, as soon as we can. What I want you to do, please, everyone, I'm going to share with you the notes now, that please register to the following accounts. Okay. Register to the following accounts, because these are the areas where you're going to have all the information related to upcoming lectures. You're going to find Facebook to be a page which has all the upcoming events. Okay, let me just put that here. So please register to the following accounts, and this is the Twitter account dedicated for Medical Education Without Borders, as well as the Facebook page and the Twitter account. So please register to these to follow up everything in the future. So do we have any questions? Okay, then. Seems that we don't have any questions. Jamil, thank you very much. It was a pleasure and an honor, and hopefully we'll see you, inshallah, in the upcoming event. Thank you very much.